So good evening, everyone, and thank you for those who've stayed on to the bitter end. I'll try and make this as fast as possible. So we're going to review 20 abstracts, and the first section is on translational. The second bit is general, and the last bit is triple negative. So this was a paper that was a research article published in Nature last year, and they talk about recurrent and functional regulatory mutations in breast cancer. We know that we get a whole lot of mutations in coding regions. We don't know much about what's happening in the non-coding regions. So deep sequencing was done in 360 primary tumors to identify mutations mainly in the promoter regions, which incidentally are found in the non-coding regions. And there was a host of mutations which were seen, and the many different loci were enriched above the expected value, and clear signals were found in the promoters of 3 genes, which you're all familiar with, implicated in metastatic cancer, breast cancer, the FOXA1, the RMRP, and the NEAT1. And they later on went to do a functional characterization of these promoter mutations, and they had these luciferase reporter assays which basically mimic the mutations found in cancer. And as you can see, it is nicely, the activity is increased in FOXA, and this also corroborates with the gel shift assays, where you can see increased transcriptional binding of the protein. And the reason that we haven't found these mutations in these promoters for so long is that they are very rich in the GC regions, and this becomes very difficult to capture by traditional sequencing methods. The second abstract is a very interesting conceptual one and talks about, in cancer cell, the genomic evolution of breast cancer, metastasis, and relapse. And it's a beautiful study which has been done. And this is a cartoon. So by sequencing primary, locally relapsed, and metastatic cancers, the group showed that clones seeding the metastasis or the relapse are disseminating late from the primary tumors. But not only do they carry the same driver mutations, but they tend to acquire more and more mutations along the way, including clinically actionable ones, and more drivers, such as the SWI-SNF and the JAK2-STAT3 pathways. And basically, it's a very elaborate article, and I would encourage you to read it. They then developed phylogenetic trees of all these individual patients, and they grouped them into regional lymph node metastasis, local relapse, and metastatic disease. And you can see that the trunk is common to all with the mutations. And the red circles you see are the divergence between the primary and the metastasis. And synchronous lymph node metastases are very similar to our primary breast tumors. The driver mutations are concentrated to the trunk, and the mutational processes which are active on the trunk then get carried down into the phylogenetic tree, into the branches, and they persist there. And for local relapse and metachronous distant metastasis, 63% extra mutations were found. So there are a whole lot of other mutations that we need to take into consideration. They then went on to develop a beautiful heat map. And what they found in this heat map is there are different sets of genes, okay? And what you see in the orange are the mutations which are private to the metastasis. And you can see whether it was the PI3 kinase pathway or the DNA repair pathway or the JAK-STAT pathway. There are increased number of these driver mutations which are seen all across the metastasis. And what was also interesting was, depending on the type of treatment given, whether it's endocrine, whether it's anthracycline chemo or taxane chemo, you have different mutations. So the stress of the treatment is producing different genomic types of metastasis with completely different genes. And this would be important for the future. There was also a very elegant article which was produced by Carlos Artiegas and his group in the Science Translational Medicine last year, and this was considered profiling of endocrine-resistant breast cancer. So what they did was they gave these patients 155 tumors, 2 to 3 weeks of upfront AI therapy, and they found a whole lot of resistant tumors. They then did the RNA expression studies, And they found that these tumors were amplified for CCND1 and FGR receptor 1. And FGR receptor 1 inhibitors are well into clinical trials, and in this group of patients are going to have an important therapeutic indication. And they also found what was common was the co-amplification of both these genes. And in addition, they also found fusion transcripts in the estrogen receptor gene itself, and this was also pretty common and contributed to the AI resistance. Now, you heard that the myriad had been discontinued for homologous recombination, but this is HR Detect. It's a relatively newer signature, and it is a pretty robust one. The only disadvantage is that it requires whole genome sequencing, which is pretty cumbersome, expensive, time-consuming, and would limit its application in the clinic. But this signature is a little different, is that it captures all the other little signatures and produces a classifier. And what is nice about it is that it has a yes-no answer. So yes, you do have an HRD defect, or no, you don't. And when you do have the HRD effect, it could not only mean BRCA1 and BRCA2, it would be the epigenetic silencing of BRCA, and it would also be others which are different mutations which are not related to BRCA at all. The same group, Davies, also looked at mismatch repair deficiency. Now, we've heard quite a bit about this today. We've heard about it in respect to pembrolizumab, and this group did a whole genome sequencing of over 640 primary breast tumors, and they found that the incidence of MMR is just 1.7%. in this group. And of course, this has implications because you know about the approval for MSI high tumors, but you can figure out that in this whole lot of or list of MSI high, I don't think breast cancer figures anywhere. So it is a pretty rare phenomenon to find in breast cancer, and my fears should be actually be testing for this deficiency in primary tumors, and with just a 1.7% positivity rate, would you not get a whole lot of false positives when you're looking for it? There were two letters which were written. These were in respect to the association analysis, so both were GWAS studies, which identified new breast cancer risk loci. This is a typical Manhattan plot, and what you can see above the red line, which is the genome-wide significance, each of these represents an individual mutation, and you can see that these are significant for breast cancer risk. So, new genetic loci were associated with breast cancer, and we are constantly finding them. High penetrant genes which are associated with breast cancer, like BRCA, account for less than 1/4 of the shared familial risk, and we are always finding new sites through GWAS studies. And two large studies, mainly in women of European origin and Eastern Asian, these looked for loci in breast cancer in general. And then there was another study which looked at new variants or loci in ER-negative women. And they found a total of 65 plus 10, that is 75 new genetic loci. And many previously unsuspected genes and mechanisms appear to be involved. And these are mainly variants in the distal regulatory elements, again in the non-coding areas, and they correlate with known somatic drivers. Each variant has a modest effect on breast cancer, but when you look at them all together, they can explain almost 14 to 20% of inherited breast cancer. Both ER positive and ER negative have distinct loci associated with them, underscoring the fact that they are biologically different, and there is a high correlation between the ER negative and the BRCA1 carriers, as you would expect. And the studies, both the studies highlight that we have a lot to learn still about the diseases. Coming more to the clinical stuff, so this is a phase 3 study presented at San Antonio. It's a double-blind, placebo-controlled trial of celecoxib in primary breast cancer patients. We know that elevated levels of COX-2 have been associated with cancer progression, and we know that COX-2 also enhances the aromatase pathway, particularly in ER-positive breast cancer. And after definitive therapy, patients were randomized to celecoxib or placebo. They excluded HER2-positive tumors. They were mainly early tumors. Half of them were node negative. There was no significant toxicity seen with celecoxib. And after 7 years, there was absolutely no difference in disease-free survival, and neither was there any difference by ER status. So this was essentially a negative study. Another very interesting study reported in the Lancet 2017 was a series of 3 articles, Health, Equity, and Women's Cancers. So they looked at the global burden of women's cancers, which was a challenge to global health, and the first article dealt with breast and cervical cancer. So in 2012, breast and cervical cancer was responsible for the death of 7.8 lakh women around the world, and this was 500,000 more than women who died from complications of pregnancy or childbirth. So this is something we need to look at. And they described the burden, so I urge you to read this paper. The survival for women with localized disease, strangely enough, was reported to be good, 90% for countries with highly developed services like Singapore, compared with only 76%. So this is localized disease we're talking about, in countries where they were less developed, India being one of them. And basically, we know that the breast cancer incidence is going up, the cervical cancer incidence is falling. These happen to be markers of our social and economic transition in the country. And if you go by the breast cancer increase, you expect to get more than, I think, 33 or 34 lakh women in 2030, and you expect to get a slight decrease in cervical cancer. And if you look at the health burden index, which consists of the longevity, the literacy, and the social standards of living in a country, you can see that as the standards go down, the burden of cervical cancer increases, and the opposite holds true for breast cancer. As the standards get lower, the incidence of breast cancer actually decreases. This was a research letter which included genetic testing and counseling among women with newly diagnosed breast cancer, published in JAMA. And women from 20 to 79 diagnosed with early breast cancer were identified by the SEER registries, and they wanted the questions assessed how much patients wanted genetic testing, not at all, or really wanting it, and they took all these factors into consideration. And in this large study, most patients reported wanting genetic testing, and only 29% reported having it. So it's not very different from our situation, and they're pretty bad. And only 39% of high-risk women and 61.7% of tested high-risk women reported having a genetic counseling session. So there is a huge gap between the need and availability of genetic counseling. And this was another paper in JAMA which looked at the risks of breast, ovarian, and contralateral breast cancer. And they looked at various factors. This was from 3 consortia, and they included only female carriers of pathogenic variants. And there are a total of over 6,000 BRCA1 and BRCA2 carriers. And one of the things they looked at was a significant family history. And as you can see, the ones that had a family history definitely had a higher incidence of both breast and ovarian cancer in BRCA1, but not so in BRCA2. Is active surveillance for low-risk cancers a viable solution to overtreatment? It appears to be so. So they chose prostate, thyroid, and DCIS. And in prostate, we already know that we are able to, it has already been adopted in practice. And we are doing PSAs and biopsies regularly. Thyroid is still in trials, but in DCIS there seems to be some limitation. We know that mammography is an option and can we actively survey these patients. So this is still to be studied. We don't know what's appropriate. We need physician and patient buy-in. We don't know which candidates are appropriate. We know that cancer progression may go unrecognized, and once a patient is being tested and has DCIS, and we tend to leave them alone, the patient's emotional health is definitely going to change or be affected. This is a lovely article, a special report in the New England Journal of Medicine. Are small breast cancers good because they are small, or are they small because they are good? So they looked at a number of cancers from the SEER database, and they had 3 prognostic groups: favorable, intermediate, and poor. They calculated the mean lead time across the groups. They estimated a rate of overdiagnosis, worked out 3 different populations, and there were several caveats in this study. So what you can see here is you can have a T1 favorable and a T2 favorable pretty close in terms of survival, but then the T1 unfavorable does worse than the T2 favorable. So it's important to know that large tumors with favorable biological features had a better prognosis than small tumors with unfavorable features, and that's something we know in the clinic. And what they later on went on to do is to look at the favorable and the unfavorable groups. And they looked at the lead time, and they found that the rate of overdiagnosis in the favorable tumors was between 40 and 61 or 63%. And in the unfavorable tumors, far, far shorter. So it makes sense to start looking at this group rather than focusing on this group where there is a tremendous overdiagnosis. This was a very nice study from the real-life ESME cohort, evolution of overall survival according to year of diagnosis in over 16,000 metastatic breast cancer patients. So it is a unique MBC national cohort, and it includes consecutive patients from French comprehensive cancer centers. And the primary objective was the impact of year of diagnosis of metastatic breast cancer on overall survival. And they looked at looked at thousands of patients, and they found that the year of diagnosis was not significant in the hormone receptor positive or negative, HER2 negative cases, while it was highly significant in the HER2 positive cases. So although the overall survival of metastatic breast cancer is improved, we know that the major contributor are the HER2 positive cases. This was presented at San Antonio this year, again another one on margins, and I'll quickly go to the results. So what they found, and compared to the previous meta-analysis, looking at the range of margins, a wider margin further reduced local recurrence, and the margin range versus positive margins. So the consensus was that the least recurrence was seen by margins over 5 millimeters. So then there was a huge debate following this, and they said, no, it's not 1 millimeter anymore, it's not ink on margin, it should be 5 millimeters. So I think this question will never be satisfactorily answered. Another interesting study at San Antonio was the risk of arm morbidity after local therapy in young survivors, and they gave them a questionnaire which was a baseline and then every 6 months, and they asked whether you'd experienced any arm swelling or a decreased range of motion over the past 4 weeks, and they had a 5-point scale. And what they found that in these young breast cancer survivors, there were very high rates of arm morbidity, and that's something that we need to keep in mind. And actually lymph node dissection definitely increased the BMI, and also a less comfortable financial status was independently associated with increased risk of self-reported arm swelling. This was a survival analysis, again presented, the mature findings were presented at San Antonio this year. So this was the survival analysis of the JEPA-SEPTO study, which compared neoadjuvant chemo with weekly nab-paclitaxel with solvent-based paclitaxel, followed by anthracyclophosphamide for patients with early breast cancer. And as you remember, if you look at the primary endpoint, it was highly significantly better with a delta of almost 9%, and the survival results were still awaited. And this basically shows you that there was an overall more than 6% difference in the DFS between the paclitaxel and the nab-paclitaxel arm. And in contrast to this was the Aetna study and its results. So here again, you had patients with HER2-negative operable breast cancer, so triple-negative or luminal B. And there were certain differences which I will highlight between both these studies, and these were also given either pacli or nab-paclitaxel. And the improved rate of PCR, 22.5% for NAB versus 18.6 after NAB, for pacli alone, did not reach statistical significance. And in multivariate analysis, it was the tumor subtype, which was a more significant factor. Now, I've tried to look at the differences between the two studies, and the doses and schedules of nab-pacli and pacli were different between these two studies. Receptor was a much larger study. Aetna had more advanced tumors. Aetna also had more node-positive disease. In Receptor, funnily enough, 33% of the tumors were HER2 positive, and this could have definitely confounded the results because the PCR rates were much higher in the Receptor. The grade of neuropathy was also quite different, probably related to the dose of NAB, and that was 86% in Receptor versus 62% in Aetna. Coming to the last two studies, this is an open-label phase 2 basket study of olaparib and durvalumab. These are results in germline mutated HER2-negative metastatic breast cancer. And what they looked at was whether a combination of olaparib and a PD-L1 agent, durvalumab, led to high or enhanced anti-tumor activity. So patients with prior platinum were allowed to enter if they'd not progressed on platinum. All of them received olaparib, 300 milligram twice a day for a run-in period of 4 weeks, followed by a combination of olaparib and durvalumab, 1.5 grams IV every month. The combination was continued till progressive disease, and the endpoint was a disease control rate at 12 weeks. And the results of the first 25 patients are available. The median age was 46. 11 and 14 had BRCA1 and BRCA2 mutations. 9 had previous platinum, and median number of chemo lines was 1. So grade 3 events or higher, mainly anemia, neutropenia, even pancreatitis, fatigue, lymphopenia and leukopenia. And the disease control rate at 12 weeks was 80%, with 8 confirmed responses and 5 unconfirmed responses. So this is a combination we need to watch out for. This is the last study I'll be presenting, and this is enzylutamide for the treatment of androgen receptor expressing triple-negative breast cancer. It is a phase 2 study that looked at the safety and activity in a metastatic AR-positive TNBC. Tumors were tested with immunohistochemistry. Anything more than 0% was positive. Patients received enzylutamide 160 milligrams per day till progression. The primary endpoint was a clinical benefit rate at 16 weeks. And there were endpoints analyzed in all the patients, the intent to treat population, and in patients with one or more post-line assessment whose tumors expressed more than 10% of nuclear AR. This was what they call the evaluable subgroup. And as you can see, the clinical benefit rate in the evaluable subgroup was 33%, which is pretty good, versus 26%. And an updated analysis of overall survival is also available. This was performed after 18 months of follow-up. The median overall survival was 12.7 months in the intention to treat population and 16.5 months in the evaluable subgroup. So that brings us to the end of the first rapid review. We will be doing the second one tomorrow. Thank you for your attention.